Good afternoon, everyone. My name is Rebecca Penn, and I am with the Substance Use Health Network. And I'm very happy to be having this webinar today. I think that we're going to be learning a lot of really important things to help us understand the role of supervised consumption services in our communities, and to help us with advocacy around making sure that we have a full spectrum of substance use healthcare options. So I would like to start with talking about where we are and our connection to the land and to each other. I'm joining you from Sogum Mi'kma'ki, which is colloquially known as Shelburne, Nova Scotia. It's the ancestral and ongoing unceded territory of the Mi'kmaq people. We come together in this community of practice from across Turtle Island. We're people who live on treaty lands and on unceded and ceded territories. Our team and community of practice members include individuals and organizations from many nations, territories, and communities, but we're all treaty people. I also want to acknowledge the people with lived and living experience, whose knowledge, leadership, advocacy, and care have shaped this work in profound ways. So much of what we know, so much of what sustains people in the face of ongoing harm comes from communities organizing, resisting, and caring for themselves and each other. And we're gathering here today too, in the shadow of immense loss. We honor the many community members, loved ones, friends, and kin who have died in this ongoing crisis. And we hold in mind all those who are grieving, surviving, and continuing on in the face of that loss. Many of us here who are attending this webinar and who are part of the Substance Use Health Network work in sectors that seek to address social and structural harms. And when we do this work, we always have to recognize that these harms are not there by accident. They're produced through colonial histories and through institutions and policies and ways of thinking that continue to shape our daily lives. Indigenous people, as well as African, Caribbean, and Black communities, are disproportionately harmed and criminalized by drug policies rooted in racism and colonialism. This work asks something of us personally, to keep learning and unlearning. And as we unlearn colonial ways of thinking and relating, we can make room for connection with the land, with each other, and with ourselves, and with those who came before us. We can find sources of guidance, connection, and healing in those. So I just want to remind us always that colonialism is not behind us. It is with us now. And we commit to working in ways that challenge racist and colonial institutions and practices, repair harms, prevent future harms, and help us build a more just, inclusive, and equitable future. So for those of you who may not be familiar with the Substance Use Health Network, I'm just going to take a moment to let you know who we are. We are a community of practice that focuses on knowledge exchange, capacity building, and really providing support to each other. We came from the National Safer Supply Community of Practice, but we grew and grew and grew, both in our numbers. We now have over 2,000 people representing all of the provinces and territories, and some from outside of Canada. And our membership includes social care and healthcare providers, as well as researchers, policymakers, and importantly, people who have lived in living experience. Really our focus now, we moved from being the National Safer Supply Community of Practice, but are now focused on how we can expand an evidence-based continuum of substance use healthcare options and advancing drug policy that's rooted in the rights and realities of people who use drugs. And if you'd like to learn more, including if you'd like to join our membership, you can go to our website. I also want to give a shout out to Reclaim. Reclaim Collective is an incredible group of folks who have been instrumental in continuing helping the Substance Use Health Network transition and continue over the past year. So some quick housekeeping pieces. We are recording this webinar. English closed captioning is enabled. You can find that on the lower part of your Zoom screen. And we're going to have a presentation, and following that presentation, there will be a discussion and an opportunity to address any questions that you have or any comments that you have. If you have comments or questions that you'd like the panelists to address, please do put that in the question and answer box. That helps us keep track of them, so they're there when we're ready to do our discussion. And there's also the chat box. One of the things that's important to us as a community of practice is that we get to know each other. So please do feel free to use that chat to introduce yourself, tell us where you're joining us from. And if you have any resources or thoughts to share, that's a good place to do that. And then, yes, we'll use the question and answer box for our discussion. And again, Tanya's here from Reclaim, helping me with doing this webinar, as Tanya does often with our webinars. So thank you, Tanya, for your help and support today. It means a lot to me.
Of course, thank you. Nice to be here.
So why are we here? We're meeting in a moment of intensifying retreat from harm reduction. Across Canada, supervised consumption sites are being closed, defunded, restricted, or politically targeted, even as the toxic drug crisis continues to take lives and cause harm every day. These decisions are not neutral, and their harms are not evenly distributed. They fall hardest on people who are already living with the effects of deprivation, criminalization, and state abandonment. Instead of responding to vulnerability with care, we're seeing growing support for policies that intensify exclusion, displacement, and punishment. So this webinar is it's the second in what's emerging to be a series asking a simple but urgent question. What happens when care gets taken away? Last month, we focused on the impacts of the abrupt loss of funding for a safer supply program. Today, we turn to what happened over the course of the year since supervised consumption services in Ontario were closed. These webinars have focused on research, on documenting impacts, grounding discussion in evidence, and helping make sense of what these losses mean. But research is only part of the story. We're now planning a panel with people who have directly lost access to services like safe supply and supervised consumption services. So please keep an eye out for that announcement and for more information about the date. So today's webinar is really about what happens when care gets taken away, what the evidence is showing, what is being lost, and who is being made to bear the cost. And I'm pleased now to pass this over to our speakers. Zoe, I'll turn it to you.
I don't hear anything either. Like, oh. Can anybody hear anything? Is it just me?
So Tanya, we can hear you, but Zoe, we can't hear you right now, unfortunately.
Okay, can you hear me now?
Yes.
Yes. Okay, thank you. Sorry about that. Hi, everyone. Okay, my name is Zoe Dodd, and I'm a community scholar with the MAP Center for Urban Health Solutions at Unity Health, and I work with the Margins Lab in Tekaronto, which is also known as Toronto and is home to the Anishinaabe, the Haudenosaunee, the Petun, the Wendat, the Chippewa, and most recently, the Mississaugas of the Credit. But it's actually home to many Indigenous people. And there are a lot of amazing Indigenous people that live here who are really fighting in the struggle for supervised consumption sites. And I just want to give a shout out to them. And here today with Uzma Ahmed, who's also from the MAP Center for Urban Health Solutions from the Margins Lab, with Dr. Gillian Kolla from Memorial University, and with Farihah Ali from CRISM. And we're going to be presenting on the studies around the closures of supervised consumption sites. And I'm going to give you a little bit of a background on where we are. And then we're going to go through our presentations. And at the end, we're going to have questions and answers. So if you do have questions, please put them in the question and answers. And then also you can have chats, have conversation in the chats. And I do also want to recognize that right now is a particularly difficult time, not only with the loss of the supervised consumption sites, it's happening all across the country, but also with the loss of our needle exchange programs, the backlash against people who use drugs, the blaming of everybody on the streets for all of social problems, structural problems that they are not responsible for. And also for me right now, I'm just like heavy. I'm going to try not to cry, but I'm feeling very heavy in my heart for the loss of a colleague who worked at one of the supervised consumption sites here in Toronto that's slated to close. The reality for many of us with lived experience is that the jobs that we have, someone's getting an echo. Is that happening for everyone? No, okay. Is that the jobs that we have are jobs that people with lived experience hold. These jobs matter a lot to people. It's harm reduction is one of those things that many of us embraced in a realm of abstinence that is really the priority of many organizations. Harm reduction carved its own way out, and it's saved the lives of a lot of people and a lot of people who do this good work. And supervised consumption sites are filled with people who work there, who are proud of the job they do and bring with them that lived experience and that care and that mutual aid. Losing people before the sites even close has happened many times, and I just want to acknowledge that today. I want to acknowledge Katera from Fred Victor Center. Her loss is profound to many people, and we're not just talking about data, we are talking about human beings. And so while we're talking about all of this, I know that we are all very aware of the context of what we are living in. Okay. If you could do the slides for us, please. Excuse my sniffles. I also have allergies.
People see them okay? Someone mentioned they can only see half of it.
Yeah, because you're in there too.
Oh, okay. Let me stop sharing.
Maybe you have to share your screen.
I'm so sorry, everyone. This is what I was talking about before
Okay.
we started. I was saying how much I miss.
Well, while you're doing that, I can continue on.
There we
So
go.
I'll just.
Sorry.
Okay.
That's awful. I'm
It's
really
okay.
sorry, Zoe.
No, that's okay. I just wanted to actually set a context before we start talking about supervised consumption sites and just about policy changes in this country, because we have been here before with policy changes with no safety nets that can have extremely deadly consequences. And I'm talking specifically about the period of time where people were prescribed Oxycontin and then deprescribed. And during those times, there was a chilling effect on doctors. We had the Ontario Narcotic Strategy. There was a focus on narcotic tracking, on appropriate prescribing with the healthcare sector, education, prevention, and addiction treatment. And in 2010, when the strategy formed, there were approximately 150 overdose deaths here in Ontario. And the struggle wide naloxone access really begins around this time. Those on the ground really started witnessing the ramifications of these policy changes. People started going to the street supply. The rise of fentanyl use began. Overdose deaths started to really climb, and much worse in the northern communities, which were hit hard by fentanyl access. This highest proportion of deaths was clustered among young adults. men, which, we see today. And, that kind of, then OxyContin was removed from the public coverage in early 2012. It was the driver behind provincial policy decisions to remove all, and it really created a horrible time for people with chronic pain or people who are using these drugs. The policy required doctors to justify what they were doing. And between February 2012 to April 2016, Ontario experienced a 22.8% drop in the quantity of drugs that were being dispensed, opioids. And following that was a 2012 strategy that was introduced by the province of Ontario. And that strategy was to prevent opioid addiction and overdose. And that was that strategy was introduced further in October 2016, which the province of Ontario today still uses this very outdated strategy. They never created their own. Many parts of the system were never changed to deal with this increase. The number of deaths caused by opioids and the number of opioid emergency visits began increasing in 2012 to 2015. There was a real significant rise. SES was implemented here in Ontario. Sorry, I'll slow down. In 2017. But to have them, the struggle for them to start was so much earlier. 2004 here in Toronto was the drug strategy meetings. In 2005, Toronto City Council adopted the Toronto drug strategy. There were recommendations for a needs assessment for supervised consumption services. There was an independent research project. It was carried out over 4 years by Dr. Ahmed and Dr. Carol Strike. And I know Gillian Kolla worked on this as well, and maybe Rebecca did too. And there was this needs assessment that was done looking at 3 supervised consumption sites for here in Toronto and 2 in Ottawa. And these were going to be fixed sites with integrated and existing service settings. The study did not call for the establishment of consumption sites for people who smoke drugs, but it did call for more research on them. And people who were on the ground wanted that kind of comprehensive injection and inhalation. That was part of the discussion since 2004. And I know because I was there. And October 30th, 2011, the Supreme Court, after Harper government went after SES, upheld the right of Canada's only supervised injection site. And this was an important time. And why I want to set the stage is because between 2005 and 2015 was the Harper government years. They were significant attacks on harm reduction. There were rising rates of HIV in the prairies, rising rates of Hep C and related deaths of both HIV and Hep C, transmission occurring in places where they were forced to do one-to-one exchanges or have no exchange at all, and overdose and drug-related deaths climbed. By 2006, we had a new government, and the 2016 Public Health Agency by 2016, the Public Health Agency of Canada began collecting better data on deaths and emergencies. And this is when, 2015, 2016 is when the fentanyl has now taken over the street supply. So I'm saying all this because contextually, we cannot talk about all of this like it just started when the overdose crisis was called an emergency in BC in 2016. All of this predates that, the struggle for supervised consumption, the struggle to keep people alive. Every death is preventable. Every death every death that happens is an event. By 2021, during COVID, we saw a rise to 3,000 deaths in the province of Ontario. That was 8 people dying a day. That was an increase of 74%. Okay. I'm moving on to our slides. So we're going to be talking about the preliminary findings of these SCS closure studies. If you can move the next slide, please. Keep going. Next slide, please. Okay. So I think, the slide before, please. I think everyone is familiar in this country. People who are on here are probably familiar with the amount of people that have died from overdose and drug-related harms in the toxic drug crisis since 2016. And we often only put 2016 because that's the year that the Public Health Agency of Canada started collecting those numbers. So I just, by intro and background was to just highlight that this was happening far earlier. And so we know over 50,000 people in Canada have died. And we are seeing the closures of sites in communities and the impacts of those closures. We're seeing, we've got 51,563 opioid-related poisonings and hospitalizations, 469 opioid-related poisoning emergency department visits. The unregulated supply keeps changing from nitazene, benzodiazepines, methamphetamine, like just new introductions all the time. And people who use drugs are facing excessive barriers accessing harm reduction and treatment services, including healthcare, including housing, and just so much discrimination has definitely increased over these last years. Next slide. So here in Toronto, where we're talking about specifically, and I do recognize that Lethbridge lost their site, Red Deer lost their site, Prairie Harm Reduction was closed 2 weeks ago, had their funding pulled. Recognizing that that we're talking specific here today, but I am not, we are fully aware, and we should all be talking about how this is happening nationally and happening in communities where after their closures, they have seen a dramatic increase in overdoses, paramedic calls, fire. It's having detrimental effects on communities. So our monthly paramedic calls here in Toronto, non-fatal overdose and fatal overdose calls continues to go up and down. After the closures of supervised consumption sites in Toronto, we saw an increase of calls. So we went from 20% to 47% increase, and then 140% increase from February 2025 to February 2026. And I mean, this is a dramatic amount of calls that have been, it's actually so upsetting because this is the thing that we said was going to happen after the sites closed. Nobody said like this wasn't going to increase. It did increase. And when we see these dips, often the dips of the lack of calls has to do with how many overdoses are being attended to in sites, and also the drug supply itself. We are at the mercy of a very toxic supply that's ever changing. Okay, next slide. So we're in an evolving policy context here in Ontario. The Ontario government in December 24 enacted the Community Care and Recovery Act, which prohibits supervised consumption sites and treatment services within 200 meters of schools and childcare centers. Just so people know, CTS is what the Ford government renamed the sites in 2019, but we just call them supervised consumption sites mostly. They require provincial approval to operate federally funded SES CTS within Ontario. So you can have a hostile government and then on a federal level have a government maybe that's more interested in actually funding them or keeping them open. But we have to have approval from the Ontario government to do that. And they also restrict municipalities for applying for federal SOS funding, which is the safe supply funding, and introduced the new funding for new homeless and recovery treatment heart hub model, which got $500 million, which is a lot of money that supervised consumption sites never got. But also organizations have not even seen that money in it. And we don't know what all of them are doing, and they don't have a model that already existed for them to roll out like supervised consumption sites did. Everything, I think, looks very different depending on where you live. But the focus is on prevention, treatment, and recovery, and this excludes harm reduction services. So no SES, no CTS, no safer opioid supply programs, no needle exchange programs, despite all of the evidence to support these decisions are dangerous. Next slide, please. In March 2025, we had a closure of 9 SES across Ontario. 4 SES closed here in Toronto, 1 in Ottawa, 1 in Hamilton, 1 in Kitchener, Guelph, and Thunder Bay. The Kensington Market overdose prevention site run by the neighborhood group remains open following the injunction. So they were supposed to be closed because of the 200-meter rule, but they're still in court. They also do not get funding directly from the province, and that includes Street Health, which is another site here in Toronto that was defunded in 2019. or 2018, sorry. Closure of 1 SES and 4 urgent public health needs sites in Toronto shelters since. So we've also lost sites that were operating in shelters that also had reduced overdose calls to paramedics and overdose deaths, and are creating chaos within the shelter system too. In addition to this act, 1 SES in Toronto was forced to close after government pulled operating funds in November 2025, despite the injunction. So it really goes against the spirit of the injunction and the legal challenge that the neighborhood group community services, Catherine Razon and Jean-Pierre Aubry-Fugler, are versus Ontario. I mean, we have 2 people who use those sites who are really standing up for everyone else, and just so much I just have so much respect for them. The arguments were heard in March 2025, and we're still waiting for the decision. So that's been a whole year now that we're still waiting for the decision from the judge. And in that meantime, the government is still going ahead against the injunction because they're just pulling the funding. Next slide, please. So Ontario, in March 2026, the Ontario government decided that they're going to end all funding for all remaining SES, CTS, and communities with a heart hub. So there was no reason actually given, just that their focus is on prevention, treatment, and recovery, and the sites have been provided with a 90-day wind down period to transition clients to a local heart hub by June 13, 2026. But again, a heart hub doesn't actually include the services that people were accessing in supervised consumption sites. So there really isn't a wind down to a program that doesn't actually meet the needs of the people's needs that were being met by SES. The sites impacted are St. Catharines, Peterborough, Kingston, London, 2 sites in Toronto, and Ottawa, 2 sites. So this is basically the total destruction of all supervised consumption sites in the province of Ontario, minus 2 that will survive here in Toronto. It's grim. Okay, next slide. All right, and now I'm going to pass it off to Uzma Ahmed from the Mass Center for Urban Health Solutions and talking about the disclosed study. Thank you.
Thanks so much, Zoe, for that really important introduction. So hi, everyone. My name is Uzma, and I'm a research program manager with the Margins Lab at the MAP Center for Urban Health Solutions, Unity Health Toronto. In our lab, we conduct community-based research related to social marginalization, harm reduction, and drug policy. And today I'll be presenting a study we completed called Disclose. And as you just heard from Zoe, she's also a very key member of our lab and of our study team. Next slide. So on August 20th, 2024, the Ontario government made their first announcement to close supervised consumption sites. They announced they would plan to close 10 sites across Ontario by March 31st, 2025. As you just heard from Zoe, there's a lot more context and things that have changed since that time. So at that time, we knew that the announcement would have immediate and widespread consequences for people who rely on supervised consumption sites, many of whom already face significant stigma and structural exclusion. We created a study to capture these impacts and wanted to hear from both client and staff perspectives, recognizing that they would experience the announcement differently and have distinct but important perspectives to offer. Next slide. So we had 3 study objectives. First, to assess the effect of the Government of Ontario's announcement to close supervised consumption sites on the well-being of people who use drugs, including their mental health and drug use. Second, to evaluate the short-term effects of the announcement on how people were accessing and using consumption sites. And third, to understand the plans and strategies of people who use drugs regarding their drug use and harm reduction strategies if consumption sites were to close as planned. Next slide. For this study, we conducted semi-structured interviews with both clients and staff at supervised consumption sites across Ontario. We recruited a total of 29 clients and 10 staff. We partnered with 7 sites in 5 cities, in Toronto, Ottawa, Thunder Bay, London, and Hamilton. We developed separate interview guides for clients and staff, which were both informed by our lab's community advisory committee. We also hired 3 researchers with lived and living experience of drug use as research assistants. Their roles were to support with recruitment and to lead interviews with participants. They were hired to draw on the relationships with community members, to help mitigate power dynamics, and to build trust and safety with participants. We also hired them as official research staff through Unity Health Toronto as a way to provide paid, supported employment experience in research. We offered all of our participants a $50 honoraria for their time. Interviews were conducted either in person or over Zoom based on participant preference and the site context. Each interview lasted about 1 hour, and with participants' consent, the interviews were audio recorded and then transcribed using either an AI transcription software or a professional transcriptionist. Next slide. So today I'll be highlighting 4 themes from our preliminary findings. And these are themes that speak to the broader attack on harm reduction and are not just about the specific issues related to the closures. We're working on a community report which will synthesize all of our data and will expand on the broader impacts of the closures. Next slide. System level betrayal. So many clients told us they didn't know when sites were closing, which sites would be closing, and the reasons for the closures. Some clients only found out about the closures during our interviews. Several didn't even know whether access to harm reduction supplies would continue afterwards. Clients and staff both described the intense emotional impact of hearing the announcement. They experienced panic, stress, anxiety, fear, rage, grief, and a profound sense of powerlessness. Both clients and staff questioned why sites were established and promoted as essential public health measures only to be taken away. Many asked why they opened at all, expressed deep distrust of public health, and wondered whether public health decisions had been a setup. Clients emphasized feeling betrayed by decision makers who had first offered care and then abruptly withdrawn it. Next slide. So as expressed here by this client and staff member, the justifications felt disingenuous and trust among the community of people who use drugs has clearly been broken. Next slide. Community safety. Throughout our interviews, clients spoke repeatedly about their values for community safety, including safety for children specifically. They described the explicit rules and norms among people who use drugs to hide substances and supplies whenever children are nearby out of respect for them and their families. As one client said, "It's almost a universal thing. When people are smoking outside, you see a kid, people say, 'Oh, kids, put your shit away.' And that's the one thing I've noticed across the board is you don't use in front of kids. And you respect that when a family is walking by, you put your things away." Clients and staff overwhelmingly predicted, previous slide, please. Just previous. Perfect, thank you. Clients and staff overwhelmingly predicted that the closures will not improve community safety as they will increase overdoses, deaths, infections, including HIV, sexual assault, theft, public drug use, and drug-related litter. Participants clearly told us that the closures will exacerbate the very issues used to justify them. Our findings challenge the dominant stigmatizing narratives that depict people who use drugs as careless or dangerous. People who use drugs are key members of communities and neighborhoods and share a deep commitment to protecting children and the safety of those around them. Next slide. Autonomy and visibility. Throughout our interviews, we also heard about the erosion of autonomy. Clients and staff were unequivocal that the closures will compromise safety for people who use drugs as closing the sites will force clients into situations that increase their visibility or conversely drive them into isolation. On the one hand, closures will force people to use in public, which will subject them to surveillance, judgment, and policing, while others will be forced to use alone and hide their drug use. Using alone will lead to fatal and non-fatal overdoses and other issues related to safety. In both cases, people who use drugs are forced into survival tactics that compromise their safety and strip them of their autonomy. As this staff member points out in the quote on the slide, we don't give people who use drugs many choices to begin with, and of the limited options available, we're taking them away. Harm reduction opponents frame these outcomes as bad choices and as personal decisions, ignoring the structural constraints. Next slide. As this client says here, they describe the way that they are trapped in these positions, and while they wish they could do something about it, they ultimately feel powerless. Next slide. Dehumanization. Clients explained that people who use drugs are accustomed to being treated poorly by the system and the public. They constantly experience judgment, stigma, are seen as a sore site, and treated like garbage. Participants emphasize that the site closures signal that the lives of people who use drugs don't matter and that they are regarded as lesser human beings. Losing access to the sites was also described as a loss of dignity, as consumption sites are among the few places where clients feel treated with respect and humanity. The policy change here, therefore, does more than restrict access to harm reduction. It reinforces and intensifies a long-standing process of dehumanization. The decision to withdraw these services confirms that the safety and dignity of people who use drugs are of minimal concern to decision makers. Next slide. These two clients are quoted here and are emphasizing on how on the street they're not cared for, they're ignored, and they're devalued. And the closures of the sites means that they lose access to one of the few places where they actually feel human. Next slide. So I want to end with summarizing 3 takeaways from the disclosed study, from our findings so far that I presented. We need to recognize the ongoing harms experienced by people who use drugs and the need to repair trust through inclusive and transparent decision-making. People who use drugs are key members of communities and need to be included in defining and implementing public safety. We need to shift the conversation about what community safety means overall, instead of focusing on moral panic and fear about people who use drugs. And lastly, we need to position people who use drugs as leaders in designing, implementing, and evaluating initiatives that address dehumanization and misinformation. Thank you.
Thank you so much, Uzma. Hi, everyone, and thanks again for joining today. My name is Farihah Ali, and I'm a scientist at CAMH and the co-NPI of the Ontario CRISM Node. So the Canadian Research Initiative in Substance Matters. It's a national research network funded by CIHR, and we work on research in the area of substance use and drug policy. So as you heard, Uzma provided an overview of feelings and experiences from people who use drugs across the province. Today, I'm going to walk you through some findings from our evaluation of the closure of one specific site as a case study, the Work Supervised Consumption Site in Toronto. This study was conducted in partnership with Toronto Public Health and the Ontario CRISM Node. And importantly, this work was also designed with input from people with lived and living experience, which is critical for understanding how these changes are actually experienced on the ground. Next slide, please. So in 2017, Toronto Public Health opened the city's first sanctioned supervised consumption site located in downtown core of Toronto. During its duration, the supervised consumption service recorded more than 164,000 visits, successfully managed over 4,000 overdoses, and facilitated over 5,500 referrals to health and social services. In 2023, as part of a city council directive, the building where the works is located was sold and subsequently purchased by a university that's located right beside the site. So essentially, with all clinical operations, including the supervised consumption service, which is hubbed within the site, set to cease by March 31st, 2025. In May 2024, Toronto Public Health partnered with the Ontario CRISM Node to essentially evaluate the closure of the supervised consumption service and its impact on clients, staff, the general public, and the surrounding community. As we all heard, in August 2024, the provincial government announced the closure of all supervised consumption services located within 200 meters of schools or childcare centers, alongside the rollout of this new Heart Hub service model. So in February 2025, our pre-closure evaluation begins, and then we ended our evaluation in October. Next slide, please. So our goal was really to understand the impacts of the closure across multiple domains. So we looked at clinical outcomes, including overdose trends, but we also looked at service access, community safety, and public perceptions. Because the reality is the impact of these services goes far beyond overdose reversal. They shape how people access care, how communities function, and how risks are distributed. Next slide, please. So the evaluation was a multi-component piece, combining several data sources. So we conducted surveys with former clients of the site, surveys with community members located around the site, interviews with staff and clients pre-closure. We conducted ethnographic observations and analyzed both crime data and overdose data. This approach really allowed us to be able to bring together findings across different perspectives. So we're not relying on any single data source, but looking essentially at how patterns emerge across the system. So for the purpose of my presentation today, I'm going to just focus on the supervised consumption service former client surveys and community member surveys. Next slide, please. So I'll start with findings from the former client survey. Next slide, please. So the goal of this particular study was to assess changes in service access, overdose risk, and drug use behavior among former clients following the closures. So individuals that used to use the site, but now that it's closed, what's happening? What are their experiences? The goal was really to look at these pieces as an indicator of what service disruption, behavioral adaptation, and changes in risk environment. So this included 30 participants who had previously used the site and remained in the surrounding area after its closure. And as you can see, in terms of the eligibility, they had to be over 18 years of age or older and present within a 100-meter radius of the site. It was a researcher administered, so we actually had a researcher on site conducting the survey. Next slide, please. So when we look at client characteristics, we're talking about a highly vulnerable population. So over half reported no fixed address. Many were in the area daily. Most relied heavily on the site prior to closure. Next slide, please. Sorry, previous slide. Previous one. Yeah, that's perfect. So one of the clearest findings is a significant decline in service access across nearly all categories following the closure. So basic need support, like things like food, clothing, washrooms, declined by 33%. Access to the supervised consumption service itself declined by 26%. Harm reduction supplies declined by 20%. Drug checking declined by 17%. And what's important here is that the site functioned as more than just a place for supervised consumption. It was a hub for multiple services. Another key finding is that people weren't choosing not to access these services. They were just often unable to. So participants frequently reported not knowing where services had moved to, uncertainty about how to access services, as well as increased difficulty navigating the system. So this is not a demand issue, it's an access and system navigation issue. Next slide, please. Yeah, perfect. When we look at risk, the findings become more concerning. So nearly half of our participants, 47%, reported increased overdose risk. About 37% reported increased public drug use. And a similar proportion reported increased experiences of stigma. So what this tells us is that risk hasn't disappeared, it has now shifted. Drug use also didn't stop after the site closed, it moved into less safe spaces. Participants reported using in alleyways, laneways, stairwells, building entrances, public bathrooms, and outdoor spaces. Next slide, please. When we look at health impacts, one of the most striking findings is that 40% of participants reported experiencing an overdose within 100 meters of the site after its closure. This is happening in the same environment, but without the protection of the site. Nearly 2/3 of participants reported that accessing harm reduction supplies had become more difficult. So again, we're seeing increased risk combined with reduced access to protective services, which is obviously a very critical gap. Next slide, please. So overall, what we see is heavy reliance on the site before closure, widespread declines in access to services afterwards, persistent risk behaviors, increased public drug use, and increased strain on both individuals and systems. The closure didn't eliminate drug use, it removed the supports that made it safer. Next slide, please. I'll now turn to findings from the community survey because community perceptions are often central to how these policies are shaped. Next slide, please. So what we were interested in is to assess changes in community members' perceptions of the site and its closure, including what they perceived as benefits and concerns related to health, social, and crime-related outcomes, as an indicator of perceived local impact and community buy-in. So we conducted 50 surveys prior to the closure of the site, and then we conducted 50 surveys post-closure of the site. So anyone over the age of 18 who are essentially present within a 100-meter radius of the site, they completed the survey in real time. It was researcher administered. They couldn't be a current or former client, staff, or volunteer of the site. So essentially anyone who lived or worked nearby or were visiting the area within that radius. So our indicators were public awareness, perceptions, perceived impact, and a few other pieces as well. Next slide, please. So when we think about the community characteristics, so average age of our participants were 45, majority were men and white. The reason for proximity to the supervised consumption services, so 30% lived in the area and worked in the area. And this was pre-closure. And then for post-closure, we're seeing similar statistics in terms of characteristics. So 40, average age was 40, majority again, male, 30% were white. The majority lived in the area, followed by 22% who worked in the area. Next slide, please. So before the closure, support for this site was actually very strong. So we're seeing 98% agreed that supervised consumption service was an essential health service. 84% were concerned about its impending closure, and 70% did not support the decision to close it. Next slide, please. When we're looking at perceived benefits, this is pre-closure. So community members recognize both health and public safety benefits. So this included the site's benefits in terms of reducing overdose risk, reduced strain on EMS and hospitals, improved public safety. The site was seen as addressing both health and community concerns, not one at the expense of the other. Next slide, please. And then we see some concerns regarding the site's presence pre-closure. So a significant proportion of the community expressed concern regarding neighborhood impacts during the site's operation, such as increased, people who use drugs in the area, as well as reduced personal or community safety. Next slide, please. When we're looking at public health concerns regarding the site's closure, after the closure, concerns didn't go away, they actually intensified. So people reported increased concern about spread of infectious diseases among people who use drugs, safety of people who use drugs, as well as increased strain on EMS and hospital services. Next slide, please. And then in terms of community concerns, the very issues people were concerned about during the site's operation became more pronounced after its closures. So, such as concerns about increased public drug use, discarded needles, drug-related activity, and overall community safety. Next slide, please. So bringing all of this together, the site functioned as a critical access point for a wide range of services. Its closure reduced access, but not need. Drug use continued, but shifted into less safe and more public spaces. And both clients and community members experienced negative impacts. What we're seeing is not the resolution of a problem, but the redistribution of risk into less safe environments. So, if the goal is to reduce overdose risk and improve community safety, these findings suggest that removing harm reduction infrastructure does not achieve that. Instead, it reduces access to care, increases exposure to risk, and shifts the burden onto individuals, communities, and emergency systems. I'll now pass it over to my colleague Gillian to share some of her work's findings.
Thank you so much, Farihah. I appreciate that. So my name is Gillian Kolla. I am an assistant professor in the Faculty of Medicine at Memorial University. I am going to now be bringing us outward to talk a little bit about some of the changes that we've been seeing in some of our data collection that's been ongoing across Ontario. Next slide, please. So this is part of a larger CIHR funded project that we were able to get into the field prior to the closures to look at some of the changes to harm reduction service provision on health outcomes. This is a large multi-method community-based study, and the findings I'm going to be providing to you today and talking about come from some of our qualitative interviews around changes in service accessibility and outcomes following the closures of supervised consumption sites. Next slide, please. That we did with both clients and staff of harm reduction programs and supervised consumption sites. So we're actually looking at two different periods of data collection, and some of this mirrors what Uzma was talking about earlier. We actually spoke with 105 clients and staff prior to closures happening, but after they had been announced. And then we went into the field after the closures occurred, and we managed to speak to, up until right now, 136 people at 8 sites in 6 cities across Ontario to try to document some of the outcomes on health, social services, and access to broader services that have been happening since the sites closed in April of 2025. Next slide, please. Next slide. And so one of the things that we were seeing and hearing a lot about in terms of the concerns that people had prior to the sites closing, one was a concern that public drug use was actually going to increase following the closures of sites because people would lose access to the supervised sites where they could use within organizations. This, in fact, is something that we have heard since the closures has very much been happening. And not only have people been forced to be using more outside and in hidden spaces like washrooms and alleyways and in parks, but one of the things that we're hearing quite a bit about is that people are hiding themselves away, which creates a distinct risk for overdose because there is no one around to intervene if an overdose were to occur. So not only are we seeing increased use in both spaces like, Tim Hortons bathrooms, public library bathrooms, and public spaces, but these are unfortunately more dangerous, unsupervised, and unmonitored spaces within the community. Next slide, please. And this is very much leading to increased overdose risk. So we're hearing quite a bit from clients and service providers of increasing overdose frequency and occurrence following the closure of sites in Ontario. One of the things that I think that's under-recognized is one of the things that was pushing towards the development and opening of supervised consumption sites was they often happened in organizations that had a lot of programming and services for people who use drugs, and where people would sometimes use in bathrooms, for example, within those organizations in order to be safe. And so they put supervised consumption sites in place because that was a place where people could go and be using under the supervision of staff and have very, very ready intervention in case an overdose were to occur. So what we're hearing is actually a reversal of this now that sites have closed in some places, where people are moving back into washrooms to use because they still want to be found in case they overdose. They're still looking for that safety. So they're using within washrooms and they're using within alleyways around the sites that have now closed because they're still very worried about overdose and they're trying to keep themselves safe. We've also been hearing quite a bit from clients and frontline service providers about quick increases in some cases in overdoses and overdose-related deaths. And also, I just wanted to flag that the closures of the sites happened at the same time that we started to see methamphetamine, an alpha-2 agonist that causes frequent and long sedation in the drug supply, in the unregulated drug supply, at about the same time that the sites were closing. And in the second slide, the second quote on this slide right now, you can see where we're hearing about people, because of this increased sedation, when they're using in public, when they're using in hidden spaces, they are at risk of assault. And so people are reporting being assaulted after using in public and experiencing sedation and getting robbed as well, which is something that supervised consumption sites, again, were able to provide a measure of protection again that has now, a measure of protection from that has now been removed. Next slide. We've also heard quite a bit in our qualitative interviews about impacts on emergency medical services calls, so calls to ambulance and paramedics, especially for the increased frequency of overdoses in communities. This is not just something that we're hearing in our qualitative interviews, but we now have data from paramedic services across the province showing that there has in fact been rises in emergency medical response calls for opioid toxicities since the closure of the sites. Across the province, it's up about 69%. Certain jurisdictions are not actually seeing this, and some jurisdictions are seeing this very, very heavily. Notably, Hamilton is seeing quite a significant increase in opioid-related emergency response calls to paramedics since the closure of sites. So there's a little bit of variability across the province, but across the province, this is definitely up. And I should note is actually a reversal of a declining trend that had been happening since July of 2024 up until March of 2025, when EMS calls across the province had actually been going down. Next slide, please. The other thing that people were very concerned about prior to the closure of the sites was concerns about loss of access to comprehensive health services. So supervised consumption sites functioning as a connection point to broader health services. We're hearing about this quite substantially in the post-closure interviews. And there's a lot of concern around wound care in particular, where people would come to the supervised consumption sites to use drugs, but they would avail themselves of the health services, see the nurse, get treatment for wounds that otherwise can be quite difficult to get treatment for or would result in emergency department visits. And so the disconnection from wound care is particularly stark in some of our data, but we're hearing across the board about disconnection from a wide variety of different health and social services since the sites have closed. Next slide. Very, very concerningly, and this echoes a finding that Farihah was just talking about, was the concerns about loss of access to harm reduction equipment. So pre-closure, again, clients were very, very worried about this, and post-closure, we are in fact starting to see the downstream public health impacts of this. We're hearing from clients who were trying to access sterile injection equipment since the closures of sites and who were not able to, and so they had to reuse their injection equipment. You can see that on some of the quotes on the slide here. And clients are very aware. They're very, very savvy, and they know that this increases risk for bloodborne infections. They know that the distribution of sterile injection equipment is a WHO priority intervention for the prevention of HIV, and that it has been since the early 1990s. And so the ban on distribution of sterile injection equipment in the Heart Hub service model is particularly problematic, as this reverses decades of some of our best practices in terms of the prevention of HIV among people who use drugs. Next slide, please. We're also hearing a lot about access to treatment services and housing. And I'm bringing this up specifically because one of the stated goals of the Heart Hubs was actually to increase access to treatment services. So we've been very, very careful to be asking about this in our post-closure interviews. And quite unfortunately, there's no reports of an increased access to either detoxification, medical withdrawal, or residential treatment services. And I think it's also important to note that the supervised consumption sites were places where clients, when they were wanting to access these services, or when they were involved in waiting for weeks and months to actually get a bed in these services, they would use supervised consumption sites. And so, as this first person points out here, that continuity of care between supervised consumption sites and treatment is now gone. And no one is reporting increased access to treatment. In fact, if anything, it has gotten worse. And interestingly, as well, some of the organizations that were trying to actually set up treatment or bed-based residential treatment as part of their Heart Hub funding models have been receiving community pushback around this. And so they haven't actually even been able to move forward with putting in place treatment because of that. Next slide. And when it comes to housing, again, this is a place where we have heard no reports of increased access to housing. People were vehement in our focus groups and in our interviews that in fact it has gotten worse. The wait lists are still there. And interestingly, some people who work in organizations that used to have supervised consumption sites now have Heart Hubs pointed out the disconnect in that this is a funding model that is supposed to increase access to housing, but that comes with no money for capital projects to actually improve access to bed-based care. And so instead, there was an attempt to find housing for people in a system that was already overstretched and overburdened, in their words, without actually having access to any funding in order to make this happen. Next slide. And so one of the things we were hearing about very, very strongly as well was the increasing in policing and criminalization that was occurring following the closure of sites. You can read some of the quotes about this on the slide about how there was very significant increases in police presence around the former sites. In fact, in some cases, people were telling us about how a supervised consumption site would close one day, and the next morning at 5:36 a.m., police would be coming on site to be moving people out, clearing them out, and arresting them. And people really talked about how this was a crackdown that was moving people out of the neighborhoods where supervised consumption sites used to function, and it was also pushing people to be forced into using in hidden places in order to avoid the police, which obviously creates a huge risk for overdose. Next slide. We're also asking people about why they think these policy changes are occurring. And unfortunately, this is one of the most stark and frankly depressing parts of looking at our interview data. We've heard from people, both clients and staff across the province. Many highlighted worries that the point of the SCS closures was simply to put in place policies that may have the predictable consequence of leading to preventable deaths of people through poverty, lack of housing, and the withdrawal of life-saving services that were able to quickly intervene when overdoses would occur. These policies are often described as policies of social murder, again, putting in place policies that will knowingly lead to preventable deaths if those services were allowed to stay open. Next slide, please. And another thing that I think, and I'll end here, and very happy to answer questions, as I'm sure all of my colleagues are. But I just wanted to point out that one of the ways in which in our work moving forward that we're framing this is as part of policies of organized abandonment, which is a concept that was developed by Ruth Wilson Gilmore. It's a theoretical framework that I think is very helpful in helping us to highlight some of the trends that we've seen in Ontario and actually across the country recently, which involves a divestment from evidence-based healthcare and social services, where funding is cut from programs that are providing life-saving services to some of our most vulnerable community members, where that funding is removed by the government from communities and from programs that are saving people's lives. In the first, under the first bullet point here, somebody points out that, of course, supervised consumption sites are not the answer to homelessness and substance use, but they're a very big part of the solution. And by pulling those back and divesting from them, it actually makes it harder to address these issues. So by pulling back from evidence-based healthcare services and funding cuts to community-based social services, this creates in turn opportunities for privatized services to fill the void that's created. And here, I think the movement we're seeing across the country towards involuntary treatment, especially as much of the residential treatment in our country is run by private for-profit companies, deserves note. And it's also important to note that a key part of organized abandonment is that in addition to the funding cuts and closure of community-based services, you see an increase in the deployment of police and carceral measures that fuel this process. And as you can see this really clearly in the words of one of the participants in the final bullet point here, this is an SCS client who comments that they worry that these new policies are policies of racial and social cleansing that, in their words, are trying to fill up our prisons with racialized poor people who use drugs. And I want to end on this concept because I think it's a very useful way of conceptualizing the withdrawal of funding and funding cuts to harm reduction programs that are happening around Ontario and across the country, especially as it's being accompanied by increasing laws criminalizing people experiencing homelessness and people who use drugs, increased deployment of policing, and in Ontario just last week, the announcement of thousands of new prison beds at a cost of billions of dollars, which I think is really representative of this trend. So next slide. I just want to thank everybody, as well as our participants, for being very, very generous with our time. Now I think that we are turning this back over to Zoe for some final thoughts. And if anybody has any comments or questions, please feel free to use the chat function. We can go into the Q&A box in the next little bit and start to actually talk about some of the findings we've seen across all of these studies. Thank you so much.
Thank you, Gillian. Thank you, Farihah. Thank you, Uzma. Okay, so there are a few questions in the chat, but I just first wanted to, I'm going to ask one of the presenters actually, because I'm curious. With all the research, this often is asked of researchers, with all the research that's generated, what are you doing with your research now? I think that especially the study, Farihah, that you presented here today about the closure of the works, which was one of the largest supervised consumption sites in the province of Ontario. It had the longest hours, it had the most visits, it was extremely busy. And what I found striking too from the presentations, I mean, I know some of this is when we started supervised consumption sites, our goal also was to, create sanctuaries for people, to reduce criminalization, to bring people inside, to have these demilitarized spaces, as we called them, where people could be safe from criminalization. And it's really sad to see this ever increasing presence of policing and people's lives, this desire that we're seeing across the country to deal with social problems by locking people away or involuntary treatment. I mean, history repeats itself. Someone put in the chat it's eugenics, and it's yes, if you look at the history of eugenics, if you look at the history of panels, Alberta starting with their forced treatment, that is very much the history of eugenics in Alberta, which went on for decades and sterilized thousands of people. So I guess, yeah, my question, I just sort of went on a little tirade, but I guess my question is really about what do you do with the research now? I know we're in a particular time, but I'm curious where we go from here. And if you're talking to policymakers, if there's anyone who's shown interest too, I think there's definitely a chill amongst bureaucrats, but I am curious.
Yeah, no, that's a great question. I think right now our priority is to get the word out. As you mentioned, like this site particularly is one of the most utilized services and sites, and really just trying to think about ways that we can push this information to decision makers, policy makers, thinking about plain language reports. We already produced a report. I plugged it in the chat. But recognizing that, that people that read it are people that know what's happening. So we want to get it on the desks of people that really don't understand the dire impacts that these closures have had on individuals. So trying to speak to get meetings with decision makers, policy makers, Toronto Public Health Board directors, to really highlight the impact and do as much knowledge translation as possible, especially in the weeks and months leading up to the final closures of all services.
Thanks for that. Anyone else?
I think that it's also just really important right now that we're highlighting to the general public, that we're trying to actually speak to the general public about what we're losing when we're losing these sites. And so I think that a lot of people don't actually even realize that there was a supervised consumption site in their neighborhood until it's gone. And I think that it's interesting because sometimes there's a lot of really, really outsized attention on these services, and an attempt to point fingers and stigmatize. That's actually something that we're hearing a lot in the qualitative interviews, is that right now there's a really, really strong move towards stigmatizing people who use drugs, people experiencing visible homelessness right now in our cities, and as a way to distract from things like there is no affordable housing available to people, that a lot of the problems that we're seeing right now are due to long-term policies of government divestment from health and social services, and that this is the increase in visibility of people experiencing homelessness and people going through really difficult moments and complex health issues is the end result of these long-term policies of divestment, and that it was never going to be one supervised consumption site in a neighborhood that was going to be able to be the magic bullet that was going to deal with all of these problems and decades of underfunding. And so I think that there's a real need to take a step back. I don't think a lot of people in the general public actually realize the extent to which this divestment from affordable housing, the fact that there's very little accessible mental health treatment for people who need them. In fact, one of the things I hear a lot is when people actually have a family member or a friend who's in need of these services, they're like, wait, there's nothing available. It's impossible to get people mental health treatment. And it's like, yes, exactly. That is actually the reality. And that's the reality for your family member when they've unfortunately been in need of them, as well as it's the reality for folks experiencing huge amounts of vulnerability, like a lot of the people that we talk about and talk to within our studies.
Yeah, I think people don't understand how, especially around mental health, like you need money to basically get therapy. You need money to be able to pay for a therapist. You need money to access services. These are all commodified services that, that doesn't fall under the purview of healthcare. And it's the same with addiction treatment. I think people don't understand that, again, this is not even under the Canada Health Act, addiction treatment services, that it falls under something else because it was never considered part of healthcare. And so people pay for a lot of those services, and they also have very limited options for people. And as you were saying in your presentation, Gillian, I think what's important for people to understand is there already is private equity in the treatment system. There already is a two-tiered private public system, a system where you can have a private program and it can be billing for public fees. And I don't think people quite understand that we already have like this American creep of companies and corporations into that. So one thing that can't be privatized or commodified is really like supervised consumption sites, harm reduction services. They don't have billable hours. People don't pay to access those services. So it is a very different model. Same with the community health center models when they were delivering safer supply programs. There are no incentives like from pharmaceutical companies. You can't receive those, and you're not billing because you're paid for salary. So not to say that all people are in it for money, but when you create a business model, there's business attached to that model. And what we're seeing really in this province is like a real destruction of our public services and a push for privatization. One of the ways you do that is by creating catastrophes. So that's just my little tirade. I like personally do a lot of research on the system and the way that it functions as a for-profit model. Um, Faria, you have your hand up.
Yeah, I was just going to quickly note that, a lot of, as Gillian mentioned, kind of like the public discourse and the general public needing to be kind of made aware of the impacts of the closures. And I think what was particularly insightful in the community surveys is that almost 100% of the individuals that we surveyed viewed the works, the supervised consumption service, as an essential health service. It saved lives. So they pronounce really impactful benefits like enhancing access to social services, reducing overdose deaths. So if the discourse and the government or policymakers want to harp on people's understanding of concerns related to public safety, are they actually speaking to community members and understanding what their perspectives are? Because when they're taking away these services, they're actually intensifying concerns among the general public when these services were actually, implemented in a community and in neighborhoods that were bringing a lot of benefit to these communities. And I think that's really important to highlight because the narrative and the discourse around what general public perceptions are is oftentimes skewed. So really needing to highlight that is important.
Yeah. I mean, we've gone away from talking about healthy communities to community safety, which has a very class dynamic to it when we're talking about whose safety. As Gillian pointed out, methamphetamine creates this, people become unconscious, people get robbed, people are outside on the street. And the other exposure people have is the exposure to sexual violence, and that you are more at risk when you are visibly outside, when you are visibly in public spaces for sexual violence and violence. Something not talked a lot about are the gender dynamics of losing a supervised consumption site and how they also operate as sites for preventing missing and murdered Indigenous women. I think of all of the people I know whose families have will contact sites and have these know that their family member is there and using that space, and they build these relationships. Those kinds of relationships are very important. They're ones that go unspoken to the general public, but are also extremely critical to the well-being of families. I think I just wanted to ask too, there was a question in the chat or a question in the thing about the Q&A about if we're seeing an increase in people dying at home, or is it, the statistic is 70% of people die at home, and do we know what that statistic is right now?
Yeah, I can speak to that. And so the evidence brief that has been shared a couple of times, I think, in the chat, has a little bit of information on this. And I also just want to caution that we're in really, really early moments of being able to speak to some of the larger population level data around the impacts of the changes to supervised consumption sites. And so I think that we need a little bit more runway to actually see what happens. I'll also note that it is really, really difficult to control for the confounding factor of the unregulated drug supply, which is a major thing that drives overdose-related deaths. But just to speak to that question, so since the closure of the sites, there has been a slight increase in the number of overdose deaths occurring outdoors and in private residences. And so I think that, kind of similar a little bit to what we saw in the early COVID period, where there was a shift in the location of deaths, when people were, people who were unhoused were outside a lot more. So it's early days on that. And so I don't want to, draw any strong conclusions from that. But yes, I think that the point though that's broader and that's really, really important to note as well, though, is that we do actually see the majority of deaths in private residences. And again, I think that what this speaks to is the really, really strong need for comprehensive services that address substance use. Supervised consumption sites are very important. They're one important part of a comprehensive range of services. I think that there's been this attempt in some quarters to frame supervised consumption sites as it was supposed to be the magic bullet that was going to solve all our problems. I think that was possibly our Premier Ford who said some variation on that. And I think that that's just, so problematic. Like we wouldn't expect putting a hospital in a particular community to address, all of the heart attacks that were going to happen. We actually need comprehensive services to meet people at a variety of different places and stages. And I think one of the important things about supervised consumption sites was the way in which they act as a front door and a place where people could get access to a variety of different services, where we could keep track of the trends that were happening in the unregulated drug supply, where we could see new and difficult. I think about when the benzodiazepines came into the drug supply starting in about 2021, and we were seeing these long periods of heavy sedation in the overdose prevention sites and supervised consumption sites, and that allowed us to act quickly. We're losing that ability to have a good window and be able to respond quickly to changes on the ground by losing the supervised consumption sites. Which is a real problem, I think, when we do see these shifts in the unregulated drug supply and we attempt to pivot to address them.
Thanks for that, Gillian. Yeah, so just to also say, people use the sites just like, as someone who worked in a site, people use the sites as a strategy so that they would use, when you're using fentanyl, especially, that it doesn't last as long as, say, heroin. So you may use the sites more often throughout the day. They're not open 24 hours. So your safety plans might be different. And I think people's safety plans would change up. People are using in other people's homes and in other places in their own homes. But people use those spaces, even when they have a home, to just keep safer. And lose them really changes that pattern and safety net for people. I recognize that we're coming up on time, and I just wondered too if we could talk about. Oh, wait, Gillian, you have something you want to add?
Do you mind if I add something really quick? I just saw it come out in the chat, and
Oh
I
my
actually
God, go ahead.
I had to cut my slide on this because because of time. The smoking. There's a question in there about impact because the majority of deaths are in people smoking. And again, I think we need to recognize this goes along with the same thought around, supervised consumption sites were important, but we weren't able to actually pivot them when people pivoted to smoking fentanyl. And when we saw the huge increase in the number of people who were smoking. The CTS funding model in Ontario explicitly would not allow for smoking services to be provided. So already, even within the CTS model, there was restrictions in place that didn't allow organizations to meet the needs of community. And I think when we think about reasons why people, might be outside of sites in alleyways and things like that, if you're not allowed to smoke and that's your primary method of consumption at the site inside, but you're still worried about overdose, then being outside and around sites is actually a really, really important safety plan that people were putting in place. So I think that we need to actually be realistic about what the issues were and where we weren't meeting the needs as people within public and community health. We were not meeting the needs of people who smoke fentanyl very well. And so I think that that's still a place where we can really think about how we can expand and better meet the needs of that group of people, because that's going to continue to be a need following the closure of sites. And that's where we really, really need to be having innovative and important responses.
Thanks for mentioning that. And just to say, like, when we say that wasn't the building of the supervised consumption sites that didn't want inhalation, there was laws in this province that actually stopped us from, like, the tobacco doesn't stop organizations from having inhalation in this. Like, the problem in them always has been the bureaucratic nature, red tape, in which for us to expand and be flexible in for the services that people need. Inhalation is one of those components that needed expansion from the get-go. It was always something people wanted, actually, from the very beginning, especially here in Toronto. I know that because I was there. Just kidding. Okay, so I feel like my internet's a little unstable and we're closing out in the last 6 minutes. I see Farihah, you have your hand up. And there are some questions in here about basics, funding, and strategies and alliances, sector movements. I think as researchers, it's a little hard to maybe really talk about that because I feel like some people on the ground really have a good sense of that. But there are things on a research level that we can and you can talk about. And before we go, maybe you all want to comment to that as well, just around there's a lot coming, right? Like there's a lot, it's happening in every sector. And so maybe we could just have like a couple comments before we close out.
Yeah, thanks, Zoe. That's exactly what I wanted to, bring up. I think, there's questions about strategies and what we can do to move forward. And I think, the priority should not only be to maintain service access, but actively mobilize communities, shape broader responses. I think there's a critical role for public health in raising awareness and shaping the public narrative. So communication, media engagement, sharing local data to highlight the real impacts of closures, coming together like how we have today to highlight different aspects in relation to the impacts of the closures, and hearing from all of you, and would love to connect with all of you to understand what's happening locally within your context. I think it's really important to support community partners to mobilize collectively. So amplifying lived experience voices, engage with local decision makers, including your MPs, can really help ensure, and I think in my perspective, that these issues remain visible and prioritized. So it's not going away. We're not going to stop. We're going to continue. As Zoe mentioned, it's been a very long fight, and we're not here today to stop that fight. So really thinking about like the goal is to both reduce immediate risk on the ground, but also build the public and political momentum really needed to sustain and strengthen harm reduction services.
And I think it's important to recognize as well that harm reduction is frequently contentious. The stigma against providing services for people who use drugs based in support and care goes against the war on drugs mentality that has predominated in our society for 50, 60 years now. And I think that we often see pendulum swings in public policy debates around harm reduction because of this. This is not the first time that we've seen these kind of pendulum swings away from evidence-based harm reduction services. I was thinking recently about, and this is partly because I'm old and I've been around for a long time now, but I was thinking recently about, the closure of all of the fixed site harm reduction programs and fixed site needle and syringe distribution programs that happened in Victoria, BC, quite a while ago. And then, that was a pendulum swing in one direction. We've seen attacks on supervised consumption sites before that have gone all the way up to the Supreme Court of Canada. And then we've also seen periods where we've been able to move forward and build services and supports for people. And so I think that in these times of contention, it's very important to actually speak to the evidence. For people within policy positions, within public health units, there is strong evidence for example, the distribution of sterile injection equipment. This is something that we know and we've known. It's cost effective, it's cost saving, it prevents HIV and hepatitis C, it prevents bacterial infections. We've known this for decades now. And so I think that we actually need our public health leaders across the board to be speaking out strongly about the importance of evidence-based public health services, even in moments of politicization and contention. It's probably more important to do it at that moment, at those moments, than it is at other times. And I'm worried right now that we're not hearing those voices talking about the reasons why, for example, needle and syringe distribution programs have been cornerstone public health at our local public health levels across Ontario for a very long time right now, and the importance of that. This is why we don't have high rates rates of HIV, for example. And so we need to actually be speaking to this and speaking out about this, because I know there's a lot of concern about that right now. And we just need to actually talk about how this is important, basic, fundamental public health.
Thanks, Gillian. Uzma, did you have anything you wanted to add?
I'm just like mindful of our time, but yeah, I think our co-presenters really captured everything, and so thanks everybody.
Thank you. Okay, I just wanted to say too, look, the fight for supervised consumption sites is not over. We have until June 13th for when the closures happen here. And I'm somebody who, well, some of us here were involved in opening one of the first supervised consumption sites in the province of Ontario. We had to run it illegally in a park for a year before getting funding and going inside. Almost all harm reduction, all of it has been a tremendous fight by people who use drugs and their allies, whether it's naloxone access, whether it's hepatitis C treatment, whether it's HIV treatment and care and support, whether it's palliative care for people who are dying, whether it's healthcare and wound care, housing. Like, the fight has been continuous. And as my friend Peter Krykant, who sadly passed away this past year from Glasgow, who opened the first overdose prevention site there, illegally running it as someone who used drugs. You know, drugs aren't bad, or drugs are bad because drugs aren't illegal because they're bad. They're bad because they're illegal. And I like think of this a lot. If we don't deal with the supply side, we will always be in this continuous problem. Supervised consumption sites, many of the interventions we do are really concessions. They're really band-aids to a larger problem in society, which is one of gross inequality, racism, colonization, housing crisis, all of that. We cannot lose sight of that. And so what the kind of work we do in harm reduction, as people say, is very sacred. It's love, but it also is rooted in evidence. It is the treatment. It is part of people's healing journeys. And it is always under attack because it is a threat to the kind of normative way of thinking about how people should be punished and people should go to jail or people should be forced to go to treatment. And the evidence is strong. Like, when you think about 65,000 overdoses reversed in supervised consumption sites across the country, you cannot argue with that. That is extremely strong evidence. And you cannot ask for that kind of evidence when it comes to some of the other models that are out there that are being hoisted upon people. You know, we know that involuntary treatment actually leads to more overdose. We already have a system of it. We know that compassion and care is really how we how we take care of people. We don't ask for more punishment. We don't lock people in cages or change those conditions. We can spend money on changing the material conditions that people are living in. So I know that it feels really daunting for many of us who've been in this work a long time and who know that compassion and care is vital, and that people who use drugs are deserving. They're deserving of life at every stage of their lives. And there is value in someone's life who uses their whole lives, which I think gets lost in the conversation when we hear like, oh, people need to go to recovery, people need to be abstinent. What that tells us is that people have no value while they're alive, while they're using. So your grandfather who drinks every day is considered somebody who has no value. That's what that kind of message sends. And that's just not true. That is not how our society should be, or the society we should want. So I'm really appreciative of this kind of research. I'm appreciative of everyone and really thankful to Rebecca and Tanya for having us on this panel. We are people who do research in these areas because we believe in system change, and we believe it's important to share this kind of work and to demonstrate and show the evidence that we already know exists out there for many of you. So, and big thank you to Reclaim and Tanya for being here and for the work that you all do. Drug user organizing and those kinds of groups are under threat, and they are vitally important to the struggle. So thank you for today. I don't know, Rebecca, you probably have a closer, and just really appreciative to be here.
Thanks,
No closer needed from me. I think we're all really happy to say goodbye on your words, Zoe. Just a big thank you from me. Farihah, you reached out a few months ago